That's right. The tree's dead there. Gonna have to cut that down. Hey, this is Dr. Nick with the ECG Academy, and we're going to be talking about branches, dead branches, bundle branch blocks this section. The first video is going to be about right bundle branch block, and I saw a picture of this tree, and I thought, what can I do with this? So what I did was I flipped it upside down, and it kind of reminds me a little bit about my conduction system, the branches in the left ventricle that supply the signal to the myocardium. And since we're going to be talking about bundle branch block, it deals with disease of these bundles. So, okay, it's a little bit of an obscure connection with a diseased tree, but let's get to it. Most of you have already watched the videos in my basic course, so you're familiar with the electrical system of the heart, with the sinus node that gives rise to the P wave as the signal spreads across the atria. And then the signal enters the AV node, gets delayed for a split second, and then is passed down through the bundle of His and the bundle branches, which results in depolarization of the ventricles. It gives rise to the QRS complex. Well, recognizing conduction system disease is not difficult, but you have to understand what the QRS complex looks like, and I did touch on this in the basic course, but we'll go into more detail. First of all, a very important concept is that the bundle branches are made up of specialized cells, long heart muscle cells that are designed for very rapid conduction velocity. These cells bring the signal down to the ventricles in a very rapid, efficient manner. The conduction velocity is literally meters per second. And if everything is working properly, if the right side of the heart and the left side of the heart get the signal more or less at the same time, the whole entire heart winds up contracting in a very efficient manner. And so what you get is a very narrow QRS complex. The normal QRS duration is usually 80 to 100, maybe 110 milliseconds. Anything greater than 120 milliseconds is consistent with some kind of conduction system disease, and you usually start looking for a bundle branch block with that. The reason the QRS becomes wide is because when one of the bundles is diseased, the signal doesn't get down that bundle efficiently. And instead what happens is the signal goes down the contralateral or the opposite bundle. And then the myocardial depolarization finds excitable cells, and the cells pass the signal from one to another like a bucket brigade fashion in order to depolarize the opposite side, which did not get the signal in time. The important concept to realize is that the bundle branch doesn't have to be blocked in order for the QRS to become widened. The key is that one of the bundles has to be a little slower than the other. And then you'll get this phenomenon where the QRS takes longer to inscribe because the signals are going down slower cell-to-cell connections instead of the rapid Purkinje system. But it doesn't have to be blocked. So the word block is a little bit of a misnomer. And I'm sure you've heard of incomplete bundle branch blocks. Well, what does incomplete mean? It's like being a little pregnant? No. You see, the word block simply implies delay. And so you can have a little bit of delay or you can have a lot of delay. And that's going to affect how the QRS looks and obviously how wide the QRS is going to be. Okay, let's get a little bit more specific. If we're looking at the limb leads 1, 2, and 3, generally if you have a normal QRS complex, a normal QRS is going to be up in 1 and it's going to be up in AVF, assuming that you have a normal axis. Lead 2 will generally be a little bit taller than lead 1 because the axis usually runs in this direction down and to the left. And lead 3 will often be a bit smaller because lead 3 is looking in this direction. Now we're going to talk about a right bundle branch block first. And so what happens when the right bundle doesn't conduct properly is that the electrical signal travels through the left ventricle normally. And so the initial part of the QRS complex stays the same. But then the right ventricle depolarizes late. Now, where is the right ventricle located? It's located on the right side of the body, but also anterior. So if I were to draw the chest here with the sternum in the front and the spine in the back, the right ventricle is more in the anterior part of the heart, and the left ventricle is more posterior. Okay, so when the right bundle is blocked to any degree, you have the latter part of the QRS complex later signals after the left ventricle has completed its sequence of activation. Now you have the right ventricle depolarizing later, and where does it show up? Well, it shows up on the lateral leads Because after all, lateral leads like lead 1 are looking, remember lead 1 is from right arm to left arm, and so it's looking for signals that are going towards the left side. And since the right ventricle is on the right side and signals are traveling away, what's going to happen is that you're going to wind up seeing late signals in the lateral leads. So what you'll see is a negative signal on the tail end of the QRS complex. Why is it so small? Because the right ventricle is relatively thin and it doesn't generate a lot of electrical current. Why is it wide? Because these signals are traveling slowly from cell to cell and it takes longer to get around the right ventricle. And why is it negative? It's negative because these signals are going in the opposite direction than where lead 1 is looking at, and so it's inscribed as a negative signal. So you can imagine that AVL is going to look much like lead 1. In fact, they usually look the same because they're both looking at the lateral wall of the heart. So AVL is going to look this way, 30 degrees above the horizontal. Now, how will that look in the inferior leads? Well, it really kind of depends on the axis, but it's not uncommon for people to see wacky delayed signals in the inferior leads because, after all, the QRS duration now has widened. You're looking at 120 milliseconds or greater for a right bundle branch block, and so in lead 3, there's going to be a late signal here. It's not exactly consistent because the signal kind of goes towards the feet, but then it kind of goes away from the feet as the vector traverses the right ventricular free wall. So there generally is not going to be a consistent appearance to the inferior leads. But the lateral leads will be very consistent with this negative, what we call a broad S wave in the lateral leads that's 1 in AVL. Now, what about the precordial leads? What about V1 through V6, V2, V3, 4? Well, remember V5 and V6 are also lateral leads, and they're going to look just like 1 in AVL with a fairly normal P wave. The beginning part of the QRS should look normal because that represents left ventricular activation, but there's going to be a wide S wave as classic pattern for a right bundle branch block. Now, what's V1 and V2 going to look like? Well, these are actually the easiest ones to recognize. Because the right ventricle is anterior, it's actually very close to V1 and V2, and so the signals from the right ventricle tend to be relatively large. Now, normally, what should V1 look like? If you remember from our basic course, V1 should have a small septal R wave and then a deep S wave, followed by an upright T. Just as a review, that septal R wave occurs because the septum is generally depolarized off the left bundle, and so the septal depolarization travels anteriorly and to the patient's right. So you get a positive going deflection initially in V1, that little tiny R wave, and that's also what explains these little tiny Q waves in the lateral leads, such as I've drawn here in V5 and V6. This little tiny Q wave is a negative deflection as the septum depolarizes and the signal goes away from V5 and V6. You get this negative signal that's a Q wave. So you get the septal R wave in V1, and then you have a normal QRS complex in general. But now what happens in a right bundle branch block is that you get these late signals traveling towards V1 and V2 because the right ventricle is depolarizing late. And so what you get is this positive deflection, which corresponds with the S wave in 1 in AVL, V5 and V6. But in V1, it's a positive deflection. If I redraw it, it's known as an R prime. It corresponds with the S wave here. But because the signal is going towards V1 and V2, it's a positive deflection. It's also very common for the T wave to become inverted because when the sequence of depolarization is thrown off, the sequence of repolarization is usually thrown off. So instead of having an upright T wave, with the right bundle branch block, there's usually a negative T wave. Now this RSR prime pattern, the relationship between the left and the right ventricular masses and the timing between the two ventricles can look like this, or it can sometimes have a more prominent R prime pattern, and in fact, on occasion, you'll see notching like this when the R wave is taller than the S wave. And we'll see different examples of this in the next few slides. Okay, but this is just a physiologic explanation as far as why a right bundle branch block looks this way. Okay, well, let's get to some tracings. Okay, so here's a normal sinus rhythm at a rate of about 70 beats per minute with a normal PR interval. And when you look at the QRS complex, it looks almost normal. I think if you measure it, it winds up being about 110 milliseconds. And it's upright in 1 and AVF, so the axis is normal. But when you glance at the precordial leads, this is where you'll see this R prime. You have an RS-R prime pattern. You can see the R prime also in V2. However, the QRS duration is not long enough to call this a right bundle branch block because the right ventricle is not depolarizing that much later than the left side. So what you have is just simply delay in the right bundle branch. Some people will call this a right interventricular conduction delay, but most cardiologists will go ahead and label this an incomplete right bundle branch block. Again, incomplete block is a bit of an oxymoron. Hey, who you calling a moron? But this is a typical example of a right IVCD. Now, if you notice, there is a little bit of an S wave that's prominent, especially here, but it's not terribly wide. Well, the next example is a little bit more of a classic right bundle branch block pattern. Here, you have a little bit faster heart rates, about 105 or 110 beats per minute. When you look at the limb leads, you see there's a very nice broad S wave here in 1 and AVL. Even the voltage is a little bit low. And you have a beautiful RSR prime in V1, V2, and even V3. The R wave is very small, and it grows, and so the R wave progression is normal. The total QRS duration here is about 130, maybe 140 milliseconds. And so we would call this a right bundle branch block. It's classic. You should never miss this. Again, you've got that little S wave there in V5 and V6. This is sort of a classic moderate degree right bundle branch block, but if you have more delay in the right bundle branch, you can get these very large R prime signals in V1 and very wide S waves here in lead 1 that's actually bigger than the R wave. Again, the QRS duration here is only about 140 milliseconds, but you're starting to see a little bit of a right axis deviation. You see the axis here? It's isoelectric in 1, so the axis is about plus 90 or so. But as we'll see in the next section, it's common to have evidence of other conduction system disease in combination with a right bundle branch block pattern. Well, the last example I came up with is this one where you've got this huge positive deflection in V1 that in essence is an RSR prime, but they're both going up and it's only a little bit of a notch here. And you got this humongous S wave in 1 and AVL representing a marked right axis deviation. If the QRS wasn't so wide, you might even call this right ventricular hypertrophy. So if the QRS was less than 120 milliseconds, you have right axis deviation, you have a tall R in V1, and you have a pretty big S wave in V6. You could call this RVH, but because the QRS is wide, in this case about 160 milliseconds, you really have to call this a right bundle branch block and right axis deviation consistent with a left posterior hemiblock. But I don't want to give away the next section, so just forget I said that. Anyway, recognizing a right bundle branch block is actually quite easy, but understanding why it looks this way when you're going forward, because understanding the physiology is what makes you an ECG expert. And after all, that's why you've subscribed to the ECG Academy, isn't it? Well, anyway, this is Dr. Nick for the ECG Academy. In the next video, we'll go over left bundle branch block in the same way. Well, until then, thanks for watching.